So, just like to start by thanking the organisers of the Think Brain Health conference, the inaugural conference for Think Brain Health. It's an absolute delight and privilege to be asked to speak at this meeting. What I'd like to do over the next 15 minutes or so is talk to you about, I guess, the research direction that we've been following over the last sort of 10, 15, 20 years within the Alzheimer's field, which is really giving us a lot of optimism and hope that through early detection of disease, possibly as far back as midlife or as early as midlife, we really have a great foundation for being able to prevent dementia in the future. And there's two sort of areas I'd like to cover in the presentation. I mean, number one is this, hopefully some sort of compelling argument that the diseases that lead to dementia do have their genesis, at least in midlife. Now, given the time constraints, I won't be able to show you too much sort of empirical data around this. So a lot of what I'll be sharing will have to be taken at face value. But I would also like to spend a little bit of time talking about an initiative here in Scotland called Brain Health Scotland, where I think we considered locally, as many are considering around the world, that it is about time that we took a lot of this research evidence and a lot of these findings that we have and put it into practice to really try our best to reduce the incidence of dementia going forward. So this simple cartoon just illustrates a little bit of what I've been alluding to already, and that is that the brain diseases, of which Alzheimer's is a good example, that lead to dementia in later life, probably start way back, at least in your 30s and your 40s. And we often refer to this as having a long silent period before mild, moderate, and severe problems emerge. But I would argue that it's only a silent period if you don't listen properly. And some of the new techniques and technologies that we have are allowing us to pick up these diseases at a very early stage, where hopefully both specifically and specific and sensitive tests will help us to detect the disease, to form a prognosis, and then, of course, to intervene. But I want to turn the clock back just over 100 years, because I think it's important to remember that when Alzheimer described Alzheimer's disease in Auguste D at the turn of the last century, he did so not on the basis necessarily of our clinical symptoms, but actually at post-mortem on the findings, and this beautiful illustration, his actual drawings of what he was seeing through the microscope in her brain. And that was, of course, the amyloid plaque and the neurofibrillary tangles. So it's worth reorientating ourselves to the fact that Alzheimer's disease started and always has been a brain disease. The challenge, of course, was back then that there was no way of detecting this disease in an individual's brain until post-mortem. So what we had to do was look at the symptoms that were developing, assumed to be as a consequence of the Alzheimer's pathology. And that is why, over the last 100 years or so, we have variously described Alzheimer's dementia, Lewy body dementia, vascular dementia, not on what we actually see in the brain, but actually in the clinical symptoms, the cognitive symptoms predominantly, that are manifestations of that brain disease. But that was okay, in a sense, I think, until probably the 1990s. Because in the 1990s, we were able to develop techniques and technologies through neuroimaging, through CSF analysis, that allowed us to actually detect the disease in the brains of individuals with these clinical symptoms. And it should have been at that moment, I think, that there should have been a pivot away from the clinical phenomenology and the way we describe people with these diseases to a more biologically based diagnostic criteria. And interestingly, as we move to things like the ATN criteria, we can see ourselves, beginning to incorporate biological processes in the description of disease. Now, one of the examples of this, probably one of the most sort of accessible examples of being able to detect disease before dementia develops, is through neuroimaging. And a lot of the analyses that we're now doing through studies like the European Prevention of Alzheimer's Dementia Study, the Prevent Dementia Program, are looking at ways to really pick up these earliest changes in the brains of people who are maybe at high risk of developing dementia in later life, or have had risk factors for dementia that have manifest through either genetics or family history, and saying, can we pick up this disease at its earliest stages? Because I think theoretically, hypothetically, and I think intuitively, the earlier we pick up the disease, more likely we are to intervene, or more likely, should I say, that our interventions will alter the course of the disease. So going back to that original slide again, I think what we have been doing up until very recently is looking at the end stage of these brain diseases in the individual who's living with the dementia syndrome. And if all of our research and all of our understandings and all of our data generation is in older people with dementia, then it's a little bit trying to understand a pregnancy by only looking at the few hours before birth. And when we do that, when we look at these brain diseases very late in their course, we necessarily look at them through the prism of memory impairment, functional impairment, and all the symptoms that emerge at the end stages of disease. Now, what we have to do and what we're beginning to do is say, well, look, if we look earlier in the course of the disease, if we look at the earlier stages, the so-called silent period or where the problems are mild, then we don't necessarily need to rely so heavily on cognitive measures or functional measures, because maybe they won't be sensed enough to pick up those early changes. What we do have to do is start having systems in place to be able to measure biomarkers, so CSF, blood-based biomarkers, neuroimaging, etc. But the other thing that's really important for any individual is not only just detecting the disease, but if we want to form a prognosis, we have to understand for that individual what are the risk factors that may have caused the onset of that disease, and also what are the risk factors which may accelerate the course, or the resilience factors which may mediate the course of the disease over time. And what this slide is simply trying to illustrate is that there is a complexity of different risk factors and resilience factors or protective factors that would play out in any given individual. And we're often asked, does head injury cause dementia? Does this cause dementia? Does that cause dementia? And I think what we have to recognize and realize is that being such a complex, disorder, lots of different risk factors will interplay on any given individual to mediate their own individual risk of developing the brain disease in the first instance and then the course of disease thereafter. So what we're now able to do through things like machine learning, artificial intelligence, is be able to incorporate lots of different data sources clustered around the individual, if you like, to give an individualized prognosis for what that individual's course of disease and course of clinical symptoms may be in the months and years ahead. So we take risk factors, both fixed and modifiable, so family history, genetics, lifestyle, medical comorbidities. That's one cluster, one dimension. Second dimension would be, is the disease already beginning to express itself biologically through neuroimaging, CSF markers? Is it beginning to express itself clinically through sensitive cognitive measures? And critically important, the fourth dimension in all of these analyses is time. Do these things change over time, whether over 6 months or a year or 2 years? And these data being collected is critically important to feed into the models, which will then allow us to predict risk in that individual. And the starting point for these disease models, of course, is research data. So projects like Prevent Dementia, the European Prevention of Alzheimer's Dementia cohort, working in concert and collaboration with others like ADNI and ABLE, will all help to unlock, if you like, some of those disease mechanisms or disease pathways, as well as mechanisms of disease, which might help understand or point to where we might want to intervene pharmacologically or non-pharmacologically. And one thing I would say is that I think one of the most exciting things moving forward is how through programs like Dementia's Platform UK, through GAIN, through Critical Path, and also this new initiative called the Alzheimer's Disease Data Interoperability Initiative, we're finding mechanisms to bring all these data sets together in environments where researchers can look across data sets to really build better, more powerful models of disease. But ultimately, we have to take these research findings and put them into practice. And what we're trying to do at Brain Health Scotland, which was initiated just in April of this year, is as part of a broad programme to reduce the incidence of dementia, we want to set up brain health clinics. And in those clinics, yes, manage, create prognosis, put in place personalised prevention plans, but at the same time collect new data from these individuals to always be refining and updating our disease models. And one of the things in terms, if you like, of the branding and marketing of Brain Health Scotland is the primary focus is midlife. So what we've done is put a program of activities together that almost deliberately a move away from the dementia from the older person to that critical period of our lives in midlife when probably the factors influence the risk of dementia are most prominent, and that's certainly what's been alluded to in the Lancet Commission report. So our objective is from 2020, Brain Health Scotland will deliver a reduction of incidence rates of dementia year on year so that we will all benefit from the lowest rates in the world. And the stuff that we're going to be doing in Brain Health Scotland, like through channels like we have today, we'll be sharing this information and knowledge with other parts of the world who hopefully can learn and develop their own healthcare systems. I think one of the things to say about Brain Health Scotland is it's not an isolated sort of brain health clinic that we're seeking to develop. It's actually got to be embedded within a public health, primary care environment. Because if you like, on the left-hand side of the screen, there's a lot of things that we will be doing in schools and with the leisure industry and lifestyle sector that may be considered primary prevention before people develop amyloidosis. If people, however, are high risk and have got early disease, then we talk about secondary prevention, and those things will happen in the brain health clinics, which I'll talk about in more detail in a moment. If we turn back the clock a few years, we're beginning to recognize that the direction of travel from a research perspective wasn't necessarily being met by what we were doing in clinical practice. And one of the facilitators, if you like, of those discussions was the possible advent of a disease-modifying therapy. But we didn't think that brain health clinics or brain health services should be established just to make way or to make it easier to use disease-modifying therapies. Of course, that will come. But in its own right, people should be given better prognosis, better personalized prevention plans to modify the risk of disease in the absence of a disease-modifying therapy. And this little cartoon is just trying to illustrate what a personalized prevention plan may look like. You take an individual who's 60 years old, you collect all that data I was alluding to earlier, you create through the risk algorithm a probability of an event happening in the future, in this case, the 10-year risk of dementia being 73%. But not only do you get the percentage probability, you also get the contributory factors to that probability, and those are what you manage. So in this individual's case, he was slightly overweight and he had poorly controlled diabetes. You manage those, you rerun the algorithm, and you find that the risk has gone down even though the age has gone up. This risk profiling and early disease detection is something that then drives forward to the personalized prevention plan. And this was alluded to in a paper that Giovanni Frassoni and others and myself published very recently in Alzheimer's and Dementia. So this is a horrible slide. I know it's a horrible slide, but this is what we're trying to do to operationalize these concepts at a clinical level here in Scotland, something called the SEED program, Scottish Early Alzheimer's Disease Detection Program. And all this is seeking to illustrate is all the different elements within a new care pathway that we have to get right before we launch the new services. But in the black boxes around the outside, you'll see that from within the DNA of this care pathway is going to be high quality data capture, so that we're always being able to update and refine those algorithms, which are maybe originally generated from a cohort study, but are obviously more valuable when they're collected in a real world setting. In a simple way, all that the SEED program is saying for an individual is that step one, you come to us because you're worried through a brain health service or through your general practitioner. We'll do some simple cognitive tests, ask some questions about your health and risk factors. And on the basis of the algorithms, we'll run over those data. If we think you need further testing, then you may have a blood test, an interview with a nurse, a physical examination, and some more detailed risk profiling. If on the basis of that, we think you need further testing, then that's where you get to the stage of maybe having a CSF sample or an MRI scan to detect disease. Once we have all that together, step 4, we put in place work with you on a personalised prevention plan. Although the program is called SEED, we have to recognize that we're not just trying to look for Alzheimer's disease in this. We also want to understand what other factors may be contributing to their poor brain health or their worry. Maybe other types of neurodegenerative disease, and maybe mood disorders, and maybe functional cognitive disorders. So these services will be able to pick all these things up. So just to conclude, I hopefully have conveyed that without showing you any real evidence, that the diseases that lead to dementia have their origins at least in midlife, and that creates the opportunity, if we can detect the disease earlier, we create a foundation for dementia prevention. And I think it's time to take these research findings and put them into practice. And as we put them into practice, we have to continue to collect data to always refine and update our disease models and improve our prognostic abilities, and also concurrently develop better therapies. So I'm going to stop there. Thank you very much for your attention, and I very much look forward to questions and commentary at the end of this session. Thank you very much.